Welcome to this session on bacterial infections of the nervous system, focusing on tubercular meningitis and neurosyphilis. Let's begin with a clinical case. A 22-year-old Nepali man presents to the emergency department with a constellation of concerning symptoms. Over the past month, he's experienced intermittent confusion, fever, unsteadiness, and a dramatic 10-kilogram weight loss. He's running a low-grade fever and has a productive cough. Additionally, he reports a progressively worsening headache accompanied by nausea and vomiting. On physical examination, his temperature is elevated at 39 degrees Celsius. Palpation reveals several prominent cervical and axillary lymph nodes. The chest X-ray shows right upper lobe consolidation, suggesting pulmonary involvement. The lumbar puncture findings are particularly revealing. There's high opening pressure, indicating raised intracranial pressure. The lymphocyte count is moderately elevated, while protein levels are decreased. Crucially, the cerebrospinal fluid shows scanty acid-fast bacilli. Both gram stain and routine bacterial culture of the CSF are negative. Retroviral tests came back negative, and there are no other signs of immunosuppression. This clinical picture is highly suggestive of tubercular meningitis with disseminated tuberculosis. The combination of CNS involvement with ring-enhancing lesions and miliary pulmonary tuberculosis confirms this is a case of disseminated tuberculosis with meningeal involvement. This presentation requires urgent treatment with anti-tubercular therapy to prevent serious complications and mortality. Tuberculosis meningitis doesn't usually occur as a primary infection of the meninges. Instead, it develops through a specific sequence. First, TB bacillemia occurs either during primary infection or through late reactivation of dormant tuberculosis. During this bacteremic phase, tubercle bacilli reach the brain. These bacilli then establish subependymal tubercles, which are small granulomas located just beneath the ependymal lining of the brain. These are called Rich foci, named after Arnold Rich, who first described them in 1933. Rich foci are essentially small tuberculomas that develop in the meninges or brain parenchyma. The critical event occurs when these rich foci rupture into the subarachnoid space. This rupture releases tubercle bacilli, tuberculoproteins, and inflammatory mediators into the cerebrospinal fluid, triggering meningitis. Following this rupture, a dense gelatinous exudate develops, characteristically located at the base of the brain. This thick exudate has several serious consequences that we'll discuss next. The gelatinous exudate at the base of the brain is responsible for most of the serious complications of tubercular meningitis. This thick exudate surrounds and entraps the arteries at the base of the brain, leading to vasculitis, or inflammation of blood vessels. This vasculitis can cause arterial narrowing or occlusion, resulting in cerebral infarction. Patients may develop hemiplegia, or paralysis of one side of the body, or even quadriplegia in severe cases. The exudate also encases the cranial nerves that exit at the base of the brain. This can lead to cranial nerve palsies, with the sixth cranial nerve, the abducens nerve, being most commonly affected. Patients may present with diplopia or double vision, facial weakness, or hearing loss, depending on which nerves are involved. Additionally, the thick exudate can obstruct the normal flow of cerebrospinal fluid, particularly blocking the basal cisterns and the foramina that allow CSF to circulate. This obstruction leads to communicating hydrocephalus, causing raised intracranial pressure. This explains the high opening pressure seen during lumbar puncture in our case. These complications highlight why early diagnosis and treatment are crucial in tubercular meningitis. The inflammatory process can cause irreversible neurological damage if not promptly addressed. The specimen used is cerebrospinal fluid obtained through lumbar puncture. It's crucial to collect multiple samples, with a minimum of 3 separate CSF samples recommended. Each sample should be 10 to 15 milliliters in volume. The CSF must be centrifuged for concentration, as this increases the yield of detecting bacteria. Direct evidence methods include several techniques. First, Ziehl-Neelsen staining, or ZN staining, looks for acid-fast bacilli. Auramine staining is an alternative that uses fluorescent dyes, allowing for faster screening under fluorescence microscopy. DNA probe techniques and PCR is the sensitive method that provide results within hours rather than weeks. 2 main culture systems. The first is LJ medium. This is a solid egg-based medium that has been used for decades. Mycobacterium tuberculosis grows slowly, typically taking 4 to 8 weeks to produce visible colonies on LJ medium. The colonies appear buff-colored and have a characteristic rough, dry appearance. The second system is the BACTEC culture system. An automated system continuously monitors bacterial growth by detecting radioactive signals produced by bacterial metabolism. The BACTEC system significantly reduces the time to detect. Now to our second case of the nervous system. A 56-year-old woman presents with ascending paresthesia and cervical spine pain. Paresthesia refers to abnormal sensations such as tingling, numbness, or pins and needles. The term ascending indicates these sensations started in the lower body and progressively moved upward, which is a concerning neurological pattern. Physical examination reveals sensory deficits below the T5 dermatome level. This means she has decreased sensation from the mid-chest level downward. She also has mild bilateral leg weakness, indicating motor involvement in addition to sensory changes. MRI of the spine shows lesions consistent with myelitis, which is inflammation of the spinal cord, extending from the C7 level in the lower cervical spine to T7 in the mid-thoracic region. This is extensive involvement, spanning multiple spinal segments. A critical clue comes from her medical history. She had an untreated sexually transmitted infection several years ago. Given this history and the clinical presentation, a CSF VDRL test was performed, which came back positive, confirming the diagnosis of neurosyphilis. She was started on treatment with intravenous penicillin G, which is the drug of choice for neurosyphilis. Syphilis is primarily a sexually transmitted infection. Neurosyphilis is a form of tertiary syphilis, which is the late stage of syphilis infection, occurring years to decades after the initial infection if left untreated. The fundamental pathological process in neurosyphilis is that treponema pallidum primarily causes obliterative endarteritis of terminal arterioles. Let me break this down. Endarteritis means inflammation of the inner lining of arteries, and obliterative means this inflammation leads to narrowing or complete blockage of these small blood vessels. This vascular inflammation results in inflammatory and necrotic changes to brain and spinal cord tissue. The disease process typically starts from the meninges, the protective membranes covering the brain, and then progressively extends into the brain parenchyma itself. This explains why neurosyphilis can present with such diverse clinical manifestations, depending on which areas of the nervous system are most affected by the vasculitis and resulting ischemia. The infection begins with primary syphilis, characterized by a painless ulcer called a chancre at the site of inoculation. This typically appears 3 to 4 weeks after infection and contains numerous spire sheets, making it highly infectious. If untreated, the disease progresses to secondary syphilis, usually 4 to 10 weeks after the primary chancre. This stage involves systemic dissemination of treponemes, causing a widespread rash, lymphadenopathy, and constitutional symptoms. The spirochetes spread throughout the body, including to the central nervous system. After secondary syphilis, many patients enter a latent phase where there are no clinical symptoms, though the infection persists. Without treatment, approximately 1/3 of infected individuals will progress to tertiary syphilis, which can occur 1 to 30 years after initial infection. Tertiary syphilis has 3 main forms: gummatous syphilis, affecting various organs; cardiovascular syphilis, affecting the aorta and heart; and neurosyphilis, affecting the nervous system. The key point is the clinical manifestations of neurosyphilis typically appear much later, during the tertiary stage. The first stage is asymptomatic neurosyphilis. Many patients with asymptomatic neurosyphilis will never develop symptomatic disease if treated. The second stage is acute syphilitic meningitis, which typically occurs during secondary syphilis. Patients present with headache, neck stiffness, and cranial nerve palsies, similar to other forms of bacterial meningitis. The third stage is meningovascular syphilis, usually occurring 5 to 12 years after infection. The endarteritis we discussed earlier affects cerebral blood vessels, causing strokes. The fourth stage is tabes dorsalis, typically occurring 15 to 20 years after infection. This affects the spinal dorsal columns and dorsal root ganglia. The result is loss of proprioception and vibratory sensation below the level of the lesion. Patients develop a characteristic wide-based stamping gait and may experience lancinating pains, which are sudden, sharp shooting pains. The fifth stage is general paresis. This involves the brain parenchyma directly, causing progressive dementia, personality changes, and psychiatric symptoms. Neurosyphilis is defined by specific CSF criteria, either a CSF white blood cell count of 20 cells per microliter or greater, or a reactive CSF VDRL test result. VDRL stands for Venereal Disease Research Laboratory. A critical point to remember: a positive CSF VDRL is diagnostic of neurosyphilis, irrespective of the patient's clinical state. This means even if a patient has no symptoms, a positive CSF VDRL confirms CNS involvement and requires treatment. However, the CSF VDRL has limitations. While it's highly specific, meaning a positive result reliably indicates neurosyphilis, it has relatively low sensitivity, detecting only about 50 to 70% of neurosyphilis cases. Therefore, a negative CSF VDRL doesn't completely rule out neurosyphilis. Serum treponemal tests, such as FTA-ABS or treponemal-specific antibody tests, should also be positive, as these remain positive for life after syphilis infection.